Good evening, everyone. Bruce, as Yvette has said, thank you so much for coming from headquarters ICRC in Geneva for this important event, and also for your work on the Healthcare in Danger project, which Len has outlined for us. Australia sends many healthcare personnel overseas to provide services, one of whom is on our panel tonight, often in very dangerous conditions, but the reality is that it is local healthcare workers who face the majority of violent threats, attacks and even death. And apart from Friday and Saturday night alcohol-related mayhem in the emergency rooms across the country, the issue of violence affecting the accessibility and delivery of healthcare seems a remote concern here in Australia. So Bruce, how then and why is the issue of healthcare in danger relevant to Australia?
Can you hear me? So, first of all, as you understood, I just arrived yesterday. So if I say mistakes, I can always accuse the jet lag. To talk about healthcare in danger is first of all a challenge to understand what are we talking about, and then to refer to Australia specifically. I was based in Beirut before taking over this position, and in Beirut I was given the role of focal point for healthcare in danger. I thought at the time that we were mainly campaigning for the 150th anniversary of the Geneva Convention. And then I came to Geneva as the medical advisor for the project. And now I'm convinced that if I'm sitting here with you all, it's that we have to raise this as an issue. It is not only about the project. We have had over the years before the project started threats against healthcare workers, difficulties at the checkpoint, hospital attacks. This is nothing new. What is new is to bring all the pieces together and to say we need to do something all together about it. All together meaning that it's the three of us around the table in this panel. I just want to say that the two main partners we had at the beginning were MSF and the World Medical Association. We have had with the World Medical Association a long-standing collaboration, mainly on detention, but nowadays we work with them and many others on this issue. I've never met anyone so far who told me that we don't understand what you're doing. For all people, healthcare in danger has a meaning, and I think this is extremely important. What can be achieved in Australia? Well, it's probably a lot. That's the reason why I'm coming to see you. I think Australia has a big role to play at the regional level. I think Australia is, from the beginning, a champion of the project with some others. I think the experience you have in Australia is not because it is a country at peace that you don't have anything to say about the issue. Previously, I was saying, you know, the difficulty with this kind of project is to define the border. Where do we stop the concern? Are we talking only about conflict? Are we talking about emergencies? Where is the limit? I've been in, you know, workshops in which people sitting next to me told me, you know, we have the same problem at home. We have the same problem. We had a meeting in London last December in which the NHS, you know, gave an incredible good presentation about violence in London. So this to say that, of course, the Healthcare in Danger project, as described by Len very well, is about conflict and emergencies. But I think as any health issues nowadays, it concerns all of us.
Thank you. And one of the pieces of the puzzle, as you were saying, one of the partners is MSF. And Paul, thanks for coming from Sydney to join us here tonight. MSF is running a campaign quite similar called Medical Care Under Fire. Could you tell us a little bit more about this, how it's more focused on the field level and how it complements the Healthcare in Danger project.
Sure. So first, thanks everybody for being here today. I really appreciate having the time and space to participate and offer the MSF perspective. We thought for a long time, what name could we come up with for our campaign? And all we could come up with was medical care under fire, because ICRC had coined healthcare in danger, which, you know, once you start trying to think about it, there's only so many names you can come up with to describe essentially something that is very similar. It was very clear from the beginning that ICRC had taken a very innovative step to say, you know, globally, this is something that we have to have a better sense of. We have to document more fully. We have to have much more awareness on a global scale of what is actually taking place and what can be done to address what appears to be, you know, an alarming trend in terms of the direct targeting of both patients, medical staff, medical facilities, etc. And a lot of the evidence that was used in the initial report came clearly from experiences shared both between ICRC and MSF and others. So it was quite logical to approach us and discuss the idea of a partnership, or at least a very robust participation in trying to work together on a number of similar objectives around the campaign that ICRC were clearly planning and committing resources to. We thought about that, and the clear complementarity was very, very clear. However, there was quite a departure in terms of where we felt our focus should be. And essentially, fairly true to MSF, we felt that if we wanted to get engaged and we wanted to put resources and do something on what we call a movement level, so across essentially all of our projects, or at least a number of them within MSF, then it had to have a patient focus. For us, the ultimate objective, if we're going to spend 3 years, considerable time and investment in this, had to be of benefit to our patients in the field. So essentially, we're driven to participate where it makes sense in this campaign of ICRC, but also we're driven very much to try and identify exactly what is going on across a range of field projects where we are confronted with high levels of violence, both against our patients, against our staff, and of course against the health sector in general, but with a particular objective of unpacking that, understanding that, and then trying to build and translate that reality into our operational strategies to mitigate, you know, those essential issues, and try and do what we can to overcome essentially this level of violence that we're confronted with in a number of projects. So when we set out to embark upon this, although we called it a campaign, the Medical Care Under Fire campaign, we don't necessarily share the objective of working towards, you know, a sort of global consolidation of information or global reflection on what trends are taking place around the world. In fact, we find that quite distracting. We think it puts a lot of time and attention and focus on trying to make sense of something that's perhaps very difficult to make sense of in a very generic way. So our focus has been to essentially pick 10 of our most problematic countries, 10 countries where we're really struggling to continue to provide care to patients, where not only are we being potentially directly targeted, or the facilities in which we work or the resources that we have are being targeted, but the impact of having targeted those programs, or the impact of having destroyed that health infrastructure in what is often very remote, resource-poor and insecure contexts, is having a massive impact then on the overall ability of a population to access healthcare when they're at their most vulnerable. So essentially what we've tried to set out to do is, number one, identify what's going on by really researching incident by incident, project by project, country by country, what's taking place, try and make some sense of that, and then try and use that to translate into operational strategy. That strategy could mean a range of things, but for example, in its crudest form, our strategy in Afghanistan currently today would reflect that we have decided, against an overwhelming and clear evidence that it is a very challenging, difficult and insecure context in which to work, to adopt an operational strategy where we focus primarily on trying to reduce mortality. In other words, our effort is invested in trying to have the biggest impact in reducing death in that country. Therefore, we're choosing to work on a hospital level, not on a primary healthcare level, and we're choosing to do it in city contexts, and we're willing to do it in a bunkerized approach. In other words, investing heavily in protection measures in order to be able to assure the safety of our field workers, the safety of those health assets, and the sustainability, essentially, of that program in that context. And that's a very different approach, a very divergent approach to you know, the standard kind of MSF mission that we would find in most country settings, even in most insecure and conflict settings. But it's an approach that has allowed us to gain not only medical credibility, actually quite expansive range of operations, but also now the opportunity to perhaps take this to a new phase, which is to focus on research on how to really overcome the obstacles to outreach and care from hospital-based settings into the much more resource-poor areas of Afghanistan that are much more volatile, much more insecure, and depend much more on a high level of negotiated access and clearly a positive perception to who you are as an organization and a clear understanding of what you do and what you offer. That gives perhaps one crude example. Another example might be in the face of widespread and fairly endemic violence as we see today in South Sudan. It's clear that resources are being targeted, we are being targeted, and perhaps health infrastructure is simply circumstantially being destroyed for a variety of different reasons by pretty much everybody that's involved and associated with that conflict. And our approach in South Sudan is a very different one. It's to actually document very clearly what this reality is, and then use this documentation to actually, as an organization, go out and negotiate and disseminate this information and try and organize both with governments and opposition forces as spaces to discuss the impact on the population that they assume a territorial control over of essentially the conduct of their warfare. So it gives a couple of examples, perhaps just to put into perspective how our approach perhaps differs. And we hope to have, because we're currently in the research phase, it's year 2 of our campaign, we hope to consolidate or have a first consolidation of what some of this research is perhaps telling us across these 10 countries by the end of this year. We've then committed to a 3rd year, and it remains to be seen to what extent we feel it's appropriate or necessary to participate further in perhaps a more global campaign effort. But certainly all of the medical evidence and data which we have collected and used, very much a methodology we've agreed and adopted from ICRC, will be fully available for the use of ICRC and the sector to further any other campaign ambitions.
That's wonderful, and I think that really illustrates the point that the movement does want to make, is that there are many actors who can address this issue of healthcare in danger, but there isn't one actor who can provide a solution or solve this issue, and things need to work at different levels, and as you say, divergent approaches are important. And as you've clearly illustrated, there are some situations where conflict has basically led to the collapse of the health system, or violence against healthcare has led to medics unable to continue their work or unable to continue training. And Sarah, I wonder if you could talk about how you've been deployed to help fill such a deficit in healthcare systems. And specifically, we'd love to hear about your role providing psychological assistance in conflict situations as the only Australian psychologist for ICRC deployments.
Thanks, Natalia. I think more generally, as we've been discussing, we're deliberately chosen as a delegate because of our technical skills. So I guess being a psychologist, that I've been chosen to go to the field and use that expertise. But I think what's important that we're all discussing here tonight is how we need to play a role in many facets of assisting with healthcare in danger. And that means your role in the field becomes a coordination role. You're trying to coordinate access to populations. You're trying to liaise with local staff to make sure you're providing assistance in a culturally appropriate way. You're also trying to assist and support the local staff who have been sometimes survivors themselves of the conflict or the disaster. So their support in their own structure and their own environment is not particularly sound. So I guess as a delegate, you're while you're chosen for your technical skills, you play a multifaceted role when you're in the field. And I think in answer to the question about providing psychological support to people in conflict zones, I think it's for all of those reasons, it's dependent on the circumstances at the time. If the most vulnerable people are the people that need the most assistance and that are able to be least accessed, then that's where your focus begins. So I think it's hard to say generally how I would provide that role, but it's based on needs and it's based on the context.
Thanks, Sarah. Something that I noticed was a common theme that came out of the various workshops and the reports that have come out of them. Although there wasn't a specific focus on medical ethics, quite a few of the workshops came out with a recommendation saying this needs to be looked at. And Bruce, would you be able to tell us a bit about the work that's been done in this area through the Healthcare in Danger project?
Yes, it's true that many questions came on ethical issues. So for the non-specialist, and I'm not a specialist of ethics either, you know, to make it understandable, you have a confidential relationship between patients and healthcare providers. And it's because of this confidential relationship that you're getting a quality treatment. There are many reasons to maintain this confidentiality. And let's imagine a context in which regularly the hospital sends statistics to the Ministry of Public Health, and all the bullet injuries are just, you know, normally declared as a process. And suddenly, because you're in a conflict or an emergency, the consequence of that is that the police gets into the hospital because most of the bullet injury belong to the opposition. So here we have a kind of ethical dilemma for healthcare providers to say, what shall we do? Shall we continue giving informations, or shall we try to anticipate this kind of situation with the government? There are many dilemmas we have in the field. So what we did was to try to look, I mean, we went to the reference first. We went to the World Medical Association. They have regulations related to conflict and other emergencies, but we went also to the nurses, to the midwife, to the pharmacist. All of them have a kind of reference in the field of ethics. So what we propose to them is to work together, to sit together, to have a kind of common denominator. So the project now is having a kind of foundation, a ground for ethical principles in conflict and other emergencies. We've been sitting, probably what is interesting, we've been sitting with the military to work on this. The International Committee of the Military Medicine, group of 100+ countries, all medical services, have been sitting next to the World Medical Association, the International Council of Nurses, and the pharmacists to define those ethical principles. Only this, I think, is an important outcome for the future. NSF has been part of the process as well, but not directly in the document, but I know they support the process.
That's very interesting because from the first part of the project where ICRC and other organisations have documented instances of violence against healthcare, it seems to come from outside. It's an external source, but there is also a responsibility, obviously, of medical personnel to avoid compromising these medical principles when they're in the working in these hospitals, perhaps with oversight by police or military. Even if it's unintentional, obviously it's important that medical personnel themselves are making sure that they operate properly.
You said jump in if we wanted to. But I think it's a really interesting point. And when we first were discussing, you know, what should be the scope of our own research, if you like, you know, you can make the scope as wide as you want. But at the end of the day, if you look at the incidents that we deal with on a daily basis, that actually impacts the ability ourselves and our colleagues, who most usually the Ministry of Health, local health staff, to actually do their job. It's far greater, the coercion, the extortion, the intimidation, which is very difficult to measure because it's almost happening on a daily basis at different levels. And really the biggest impediments or the biggest obstacles are often these. And this is a form of structural violence. It's what often intimidates staff to the point where they're unwilling to work in particular areas, or where there is no patient confidentiality because patient information is required, and nobody will take, it becomes very difficult as an individual health worker to assume that ethical responsibility towards your patient. So really this range of issues that confront the rights of a patient and the role and responsibility of a health worker in terms of volume are sort of an everyday reality in comparison to the much more targeted or violent acts against healthcare in these kinds of settings. But once you start to try and measure that in this kind of approach, it becomes very, very complicated. One, to really even have a clear idea of what's taking place, and to be able to account for what essentially that means in terms of a direct or an indirect impact on your ability to work or on the ability of your colleagues to work. But it's a huge challenge how to manage questions of medical ethics in these contexts of structural and cultural corruption, violence, etc.
Especially when people's lives can be at risk in terms of having to comply with medical ethics or not. Sarah, how important was it for you to demonstrate neutrality and impartiality on the ground in your experience?
Crucial, I think. What underpins the movement is the fundamental principles of neutrality, impartiality and independence. And I think with the history that has come before, there's an understanding about what the emblem or the movement will represent. So I think when you're in the field, there's an obligation to be demonstrating that throughout all of your interactions with people, and not only for the purpose of the integrity of the movement and the integrity of what you're doing, but also to model, I guess, a role model, a way of providing healthcare that remains neutral. So I think you're doing it for several purposes, and I think it, for me, it provides a safety in the sense that there's the protection, but also a safety in the sense of enabling access in an appropriate way.
On that topic of neutrality, I noticed in the MSF report on Afghanistan earlier this year, it was mentioned that the hospitals were used as polling stations during the government elections, and that this could possibly mean that hospitals face increased risk of attack because they're no longer a neutral place just for medical care. Why is it so important, in your opinion, that health facilities remain zones of neutral medical care only?
Yeah, I mean Afghanistan's a very good example because operating in Afghanistan, nothing is perceived as neutral. No, there's no neutral space, and that's a huge problem. It's was one of the key issues that we faced when we tried to reach an agreement. And we tried to reach an agreement with everybody, be it US coalition, be it so-called Taliban, be it government or others, because the perception towards allowing access for anyone to a location is that location is serving a purpose over and above simply medical care. So the only way to overcome the barriers that the local population faces is to ensure that you can reach an agreement across all parties, that they will all recognise and acknowledge that space will basically remain off limits for them, and that they will respect that anybody should have free passage to that space because they're coming purely on medical grounds. But everybody has another stake locally in what's going on, who's moving where, what's taking place, who's getting treatment, who isn't. And often, unfortunately, hospitals as other facilities are seen as locations where you can essentially gather information or undertake other activities. And that's the same whether you're sitting in the military of the United States or you're a member of the Taliban. And all of those key actors, be it Taliban, United States, or the Afghan government, in our discussions with them, wanted to use us as instruments for information flow to them because of the location we would be based in Afghanistan, and where our clinics were. So it's very, very clear that this question of even the role we aspire to and the neutrality we expect and the impartiality we demand in the delivery of our services is seen as negotiable by everybody who's in that space. So it's a very, very difficult process to get that kind of agreement. And from a patient perspective, most of the medical infrastructure and facilities are identified either as pro-Taliban, pro-government, etc. So you will not go to a facility that is, or if you do go, you will be identified with one party or another in that conflict. And the concept of there being an independent space, it largely doesn't exist.
Yes, actually, Bruce, I was going to ask, there are two workshops, Pretoria and Ottawa, I believe, on the safety of health facilities. And the participants in these workshops also raised the issue of the perception of healthcare facilities. And they had some recommendations about that. Would you like to talk about that?
Yes. Maybe just on the last point, we've had endless discussions on the concept of neutrality, and so if you read, you know, the principles of the Red Cross, you'll find a lot, you know, written on this, and within the Geneva Conventions there are also a lot about it. Talking to you know, local healthcare providers, I found easier to tell them, you don't need to be neutral. You have the right to have an opinion, but the day you're in the position to treat someone, you need to be impartial. And I found that, I give you this just as a tool that has been discussed in many of the workshops, is I think it was easier for the people to understand the concept of impartiality and vis-à-vis the neutrality. Now concerning, so we had two workshops on physical safety of health facilities. So we've been discussing many things. We've been, you know, discussing engineering, how to protect hospitals, and I think, Paul, you mentioned bunker. I think this is an important aspect that came out mainly from Pretoria, is to say that whenever you protect your hospital, you have to make sure that at the end of the day, it doesn't look like a bunker. It doesn't look like a place that needs to be attacked. So it's always quite complicated. You know, we've played usually with 4 keywords. Two of them are access and security. If you want to help patients to access the facility, you need to make sure that the security of the patients getting into the hospital will be respected, as well as for the healthcare providers coming to the hospital. And sometimes we've had people in our workshop saying, what shall we do in places in which they have, you know, the second blast? You know, you have all the volunteers and the ambulances coming on the spot to rescue, and then you have the second blast killing the people coming. So this balance between access and security is quite complex in conflict and emergencies. And then the other 2 keywords are perception and acceptance. This is something all of us that have experienced that in the field, we know that we have permanently to explain at the checkpoint with the communities, with the local leaders, what we are doing, why we are doing it. Otherwise, 3 months later, the people at the checkpoint have changed. Maybe the local leaders have had a bad experience that need, you know, some explanations. So this whole question of perception and acceptance is a permanent problem that needs to be balanced. And And this came out very strongly when you have to protect a hospital, you have to make sure that it is well perceived and well accepted before you try to do anything else.
I'd like to move on to two of the other workshops in this series in the Healthcare in Danger project, one in UK and one in Egypt. They were on the rights and responsibilities of healthcare personnel. And the recommendations from these workshops emphasise the need for healthcare workers to be protected as they go about their roles, often as volunteers, to be protected both physically as well as mentally. Paul, how does MSF address its duty of care to its personnel, and how do you reconcile that with the humanitarian imperative?
Wow, it's such a loaded question. It's a very important one for us, actually. And interestingly, we're trying to develop a paper that we'll try to publish that unpacks the dilemmas that we face as an example within MSF around this challenge of how do you live up to your responsibilities of duty of care when in fact you're putting people, clearly in harm's way, which, let's face it, isn't necessarily that different to sending a fireman into a burning building. It's at the end of the day, it's your job. But there are huge ethical challenges, there are legal challenges, what we're bound and to comply with, for example, and work health and safety legislation here in Australia is certainly not what we can fulfill in the majority of our projects overseas. And I think perhaps the biggest controversy within MSF, certainly, and I'm sure it's true for other organizations, is we often fall back on this qualification that we are willing to assume risk. There is no zero risk game in the humanitarian world. We understand that, but as long as the risk justifies, as long as the needs justify the risk, then that becomes an acceptable level of risk. And that there's a risk tolerance within all organizations, and therefore the greater the need, i.e. Somalia warrants far more extreme levels of risk-taking and perhaps more extreme operational models, although of course they're not the ideal. But across MSF, even across 5 countries, our interpretation of what those risk levels might be and how we qualify those is not a constant at all. And clearly, when it comes to questions like our duty of care, well, we can prepare people, we can ensure they give consent, we do everything we possibly can to ensure that the people fully understand the risks that they're going to be assuming, and then we can put a range of measures in place, such as undertaking thorough risk analysis, being able to translate that risk analysis into appropriate measures to manage teams on the ground in those kinds of security settings, having evacuation plans and logistics and perhaps protection measures, and surely and hugely significantly building acceptance within communities. And probably the one thing you didn't mention is negotiating what stake people are going to get out of your presence, because everybody has an agenda. And at the end of the day, you have to understand what their agenda is in allowing you to have a presence in that area. It isn't purely through acceptance. Radical armed actors are not going to simply accept you. They are going to want to see an advantage for them in return. And you have to understand that. You have to clearly navigate your way through that. And you may have to make certain compromises around the way you work or what you do in order to be able to meet conditions in certain circumstances with certain groups, not just one, but multiple groups. So all of this is part and parcel of living up to our duty of care. But it unfortunately, there are many things that undermine that we do not have full control of. There are of course, all of the external factors. We can accept that. We can't take responsibility for what we can't control. But probably the one thing that undermines most of our security operations today within MSF is our own ability to maintain the right level of people with the right skills for a long enough duration in these kind of complicated environments. And they're difficult places to live. It's not the kind of environment that necessarily encourages people to stay. But we understand that, it takes a year to really understand what the hell is going on very often. And when you have that level of understanding, you can't risk losing that overnight. And we you know, have probably too many missions where we rely on too few people today to be able to manage the level of understanding and analysis that would really not only enable us to have all of that alphabet of practices in place, but to really fulfill that, you know, core responsibility in terms of duty of care. And that, I think, is a real challenge for most organizations today.
Absolutely, thank you. And it's not just the protection while they're in the field, but we have volunteers who are experiencing fairly traumatic things. So it's important also to have psychological debriefing or psychological assistance, perhaps when they've come back from mission or while they're on mission. And Sarah, you've worked with the movements or the International Federation of Red Cross and Red Crescent Societies Reference Centre for Psychosocial Support. How do they help provide assistance to volunteers who are exposed to trauma?
The role of the Reference Centre essentially is to produce materials which are to support the assistance of trauma-related exposures. So their role is about documentation, about handouts, about information to provide to people in the field. So I guess in my role I've utilised many of those materials in a number of ways. I think being in the field, providing psychological support is on a number of levels. You're working with beneficiaries around their exposures. You're also working on a field worker level with the volunteers about assisting them to understand or process their exposures. You're helping people with workshops to be aware of what the stress exposures can do. There's also opportunities to provide debriefing in the field if particular incidents happen. So it's very tailored to the individual exposures of the person. But I think at the same time you're also trying to embed organisational structures that understand how this can impact people. So that might be things like trying to ensure that volunteers are appropriately recruited, that the people that are chosen for these roles are suitable for the roles and what they're likely to encounter, that they're trained appropriately, so when they're exposed to something they know what to do in response to it, what's a normal reaction, what's not a normal reaction, how to assist themselves or to seek out alternatives. I think one of the things that draws people to the humanitarian field is the sense of altruism, the need or want to do something for other people, and with that can also be a vulnerability factor for people, that they always want to do more. They always want to do more than the access allows, more than the resources provide, more than their physical limits of resilience cope with. So I think it's about the training element, I think, is really important in preventing or buffering the longer term impacts that humanitarian work can have on people in these types of environments. So I guess I think the role of mental health or psychosocial support at a number of levels is important, and we could certainly do more over time to embed it in many ways.
And on the topic of providing psychosocial care to beneficiaries, so people that you're meeting when you work in the field, usually the image of providing medical care in conflict is of emergency response, rapid response, so racing ambulances, critical first aid, life-saving surgery. But healthcare is more holistic than that. And can you tell us about why it's important to provide psychosocial care as part of that emergency care, not sort of further down the track?
Thank you. It's a very passionate question to answer. Well, we know that well-being is made up of a number of elements: physical health, emotional health, or social and spiritual well-being. So, of course, meeting the life-saving and immediate needs of people is the most essential element to begin with. But what we also know is that how somebody is treated or handled when they've had an exposure to something impacts on their ability over a longer term to deal with the emotional, social and spiritual elements of it. So I guess in answer to the question, it's crucial at all phases of a disaster or a conflict scenario to have awareness of that we can change the trajectory of somebody's outcome by intervening early. And so I think that there's a number of ways of doing that. The emotional elements are usually addressed by the mental health programming activities, so that might be distributing information about what you should or shouldn't be doing or feeling at certain stages and phases of a situation. The social elements are about trying to recreate connectedness or repair fractures in social communication, which is an important part of people feel, particularly in collectivist cultures where we often spend a lot of time. People don't exist as an individual outside of their environment, outside of their family, outside of their networks, what they're connected to. So to when those things become fractured, it impacts on people's well-being. So there's a number of ways of addressing that, and that is mental health programming that starts to try and rebuild cohesion. And in terms of addressing the spiritual elements, that can be very practical things, such as an example in Pakistan. There was a particular community who'd lost their mosque through a disaster, and faith being a way of healing for people and making sense of the world and themselves. One of the most important mental health or psychosocial support functions we could play was to assist in rehabilitating the mosque to a form where people could go to a place that connected them with others, they connect with their faith, and that helped people to recover. So I think the way in which mental health is can be utilised is on all of those levels, and I think I'm a passionate advocate for having it involved in all parts of the emergency recovery and longer-term development aspects of what we're doing. And we're still learning, and I think the panel members I've talked to offline tonight would agree that it's something that we're only really understanding, that we can fix the physical injuries at the time, but it's the emotional scars that last for people, and by helping at different phases we can reduce the impact of that.
And I would add that in some contexts where what we see as physical problems are not physical problems, they're rooted in deep trauma. And that reminds me of working in Colombia, and the majority of the patients that came for clinical diagnosis would be referred, and it was through counselling that they actually started to recover from a range of physical disabilities.
You've got me started. I can give you some examples from the Philippines recently also, where in some of the medical facilities, local medical facilities, doctors were estimating that 50% of their presentations for physical ailments had a somatic or psychological origin, so meaning that people were internalising distress, we do it in Western society as well. It's common for people to have physical symptoms as a representation of something they're not managing internally. So it's that education of local medical staff also is a crucial part of the role that we play too, in helping them to understand and conceptualise how they can refer their patients to appropriate treatment.
I just want to say that all what you've described came out of all the workshops we had on healthcare in danger, and the Psychosocial Support Center in Copenhagen participated in most of them. What I found always very interesting in this special field is that it is both an operational concern. So you have, the beneficiaries, they don't have only physical injuries, they have also, they need also psychological support, and it's also a human resources problem for any institution. And I think some of them have difficulties to use one to help the other. So I think there are tools that can be used for beneficiaries that are useful for human resources management and vice versa. As we were talking about security issues, I just want to say that we had a very, very hot debate within the institution about the so-called personal protective equipment. So are you protected, by the symbol? I wear the Red Cross or the Red Crescent or the Red Crystal and I'm protected? Or is it better with a bulletproof jacket? Do you have an opinion? I can tell you this has led to very, very hot debate. Including people saying, you know, we have in our national society personal protective equipment, but the problem is that nobody uses it. So we ended, and you will find this within the recommendations, there are issues for which we have pros and cons. And then according to the context, you can take your own decision.
Sorry, I don't want to drag the conversation out, but there's just one interesting, I'll just throw it out there. It's also in the field of providing mental health support that we've run into considerable problems and being accused of information gathering. There's an interesting element to explore at some point.
That's very interesting. Just because we are at a university, and I believe there are plenty of people in the audience in academic circles, one of the audiences, I suppose, that the Healthcare in Danger project wanted to raise awareness among was academic circles. And Bruce, there were some tools that have been developed for universities and academic institutions to better understand the issue of healthcare in danger, or to teach it in law faculties or health faculties, etc.
Yes, so on this, you can find on the website, there is an e-learning on the legal framework for healthcare in danger, a very, I think, basic and useful way to make the difference between what are the rights and responsibilities of health personnel in case of conflict with IHL, in case of when the legal human rights is applicable, or when medical ethics are applicable. Excuse me. And so we have the one e-learning on the legal framework, and another one coming soon on responsibilities of health personnel. We have a book, but of course we know that the book can't be shared everywhere. So we have developed this e-learning, and we hope that the network developed through the community of concern will be a network useful to get people to know at the ground level what can help them to achieve their work.
Thank you. I think that I could probably spend the rest of the evening chatting with you, but for purposes of time, I think we'll hand over to the audience if there are any questions that people would like to ask of our panelists tonight. Please wait for the microphone to come to you.
Thanks. This is a question for Paul. I was interested in the story you were telling him in Afghanistan and having arrangements with the various combatants to allow access to your hospitals. And the concern struck me is, do you find, or is there a risk, and how do you manage it, of the combatants actually bringing the combat in with them? They may not intend to. They're coming to you for medical care, but find themselves in the hospital with their putative enemy next door. Is that a risk, and how do you manage that?
Yeah, I mean, it's a risk, and there are, there are many examples in many of our projects where it's been a problem, but it shouldn't be. And part of our dialogue is that our facilities are there to cater for anybody who's hors de combat, injured in combat. They become a patient, and under international humanitarian law, they're protected as such. But there may not be necessarily that perception, and there are also many challenges around, what legal access does a government of a country or its security forces have to a hospital, if within that hospital there is a terrorist or a member of an armed opposition group or whatsoever, or a criminal, and they have legal access, clearly. However, they have to respect what is the appropriate requirement in terms of space to provide medical care, which that patient has a right to. So it's one of many areas that we have to talk through very clearly with everybody when we talk about what provision of medical care means. And it's also an opportunity, because it's often one of the potential advantages to any armed group, knowing that there will be medical infrastructure within a conflict setting, because clearly that provides a medical service in the event that somebody's injured, if they don't have that provision themselves. So you know, it can be problematic, and there are certainly cases quite recently where we've had intrusions into hospitals, particularly to remove people or even to directly target them within those facilities. But by and large, that's less common. It's much more an issue of having people barging into your medical space with no regard for the fact that it's a medical structure as such, and forcing their way in order to have access to people. And that's something that we face equally with you know, local police forces or military, as we do with, you know, potentially opposition groups, etc.
Any other questions?
My question is for all the panellists. I wonder, as healthcare professionals, to what extent do you think the legal frameworks that are already in place for the protection of healthcare professionals are adequate to the task, or is it not a relevant consideration when you're on the ground and it's just a matter of responding to a particular situation?
That's a good question.
So, I mean, the only one missing on the panel will be a legal advisor. So, I mean, there are many legal advisors in the room. You know, I think from my perspective, I want to say that the legal framework is both indispensable and also not enough. You can have the best legal framework, you know, if there is no willingness in the field, you can just forget about that, and you go back to the negotiations, you go back to the discussion on perception, acceptance. Let me maybe give you an example that is not directly healthcare in danger, but very comparable. Health in detention. You know, there are some perspectives, there are some legal framework for what are the requirements for health in detention. But if you talk to the director of the prison has only one objective, which is security. And you can discuss, you know, I've been visiting a lot of prisons around the world, and I can tell you that if you don't talk security with the health director, you end nowhere. The day you manage to bridge the gap and say that maybe if you invest in health, you might get a better security, then the discussion starts. And this has nothing to do with the legal framework. And I have to tell to my colleagues here in the room, legal advisors, that I respect all legal frameworks.
Was it just legal frameworks or protection frameworks?
Specifically legal.
Legal, yeah. Then I think you've summarised that pretty well. But I mean, for us, the reality in many places where we work is you know, the legal framework is a fiction if it doesn't translate into actual protection measures, and you know, the resources that would be required in many of those contexts to actually be able to assume protection responsibilities on behalf of civilian population is simply not there. You know, and the Central African Republic would have been a clear example where in the absence of there being any real meaningful protection in terms of presence, you know, a virtual genocide has taken place in terms of the ethnic cleansing of a group within a country.
Craig, thanks.
As you've been talking, I've been trying to imagine just how difficult it must be to negotiate with the parties, whatever they are, governments, oppositions, militias within militias. I mean, it must be a bit of a nightmare, but this led me to think of something else which I don't quite understand from all that you've said, because you have healthcare workers and hospitals and doctors and so forth and so on. But to manage to create this space, contested and or whatever, and vulnerable, you must also have, I'm not quite sure who does this. You have translators, you have negotiators, you have local people, you have informants, you have spies. I mean, you must have all sorts of people that help you to do this. And are these people from outside, or are these local people that you hire, or just how does it work? How do you go about, apart from the problem of identifying who the parties are, how do you go about talking to them, accessing them, coming to some agreement with them? Are there intermediaries and so on?
Yeah, I mean, of course, there's no one-size-fits-all approach, but it's essentially most of the same elements come into negotiating access. So, I mean, we are a medical organisation, and we always work through whatever medical network is in place or was in place. In most countries, there is or was, you know, a health map, and there's a range of medical providers, even local, local people nominated within their communities that take a responsibility for health. I guess the first point is we don't rush. It takes a long time to negotiate into access into a new area, and in doing so, you have to go step by step. And we essentially use key local staff, people that we know have trust and respect, local knowledge, and we gradually start to build a network of interlocutors. So people with some prominence locally who have access to people who actually have positions of authority or have direct access to people who are controlling territorial areas. In other words, a range of different non-state actors. And we go, of course, through all of the formal channels within a country simultaneously to ensure that, you know, if we're going to be working in a given area, that it's fully understood that we have the authority to do so, that the terms and conditions under which we can work have been nailed down. And we adopt transparency. It's essential. So, you know, people we talk to who are armed actors, they're very well informed, and we need to be very, very clear with them who else we're talking to and with what agenda. And it's a painstaking process, and we very often start projects in quite a small way. And what it really comes back to is as we said earlier, identifying, you know, what do we have in common? What can, not only can we offer the community, but what can we offer in the way perhaps of assurances around the concerns that other stakeholders are going to have of having, you know, the presence of an international organization in a particular area in a country where, you know, the stakes are completely different. And so we put experienced people who have a good deal of experience in giving oversight to these processes, and we work by developing our local capacity and identifying who's who, and then working through the local community, which is absolutely essential. And at the end of the day, it's the local community who have the biggest stake in your being there. They need your services, and they also have a certain level of leverage and influence over others. And I would answer that the biggest protection, at the end of the day, it's not necessarily if I'm wearing an MSF t-shirt or a bulletproof vest. It's that over a period of 2 or 3 months, we've treated 500 local people. And who knows, some of them will have come from local armed groups who will have been associated with them, or it's their girlfriends or their daughters or their children. But at the end of the day, that has a greater impact on building an identity than probably anything else.
There are contexts in which the best way to solve a problem of access is to talk to some leaders in the prison. Just to give you an example, there are many, many ways. You know, I fully agree with what Paul has said. You really need to spend a lot of time to try to understand. And there are, you know, we do also mistakes. We can do mistakes, for instance, employing just one part of the population and forgetting another part. And we also pay for our mistakes. So just to say that it's a kind of process And there are periods in which we are very successful, and there are periods in which we are not successful. The key word is really the security of our people. That's what we are playing with sometimes, and we try to limit the risk as much as we can.